As a nurse, have you ever walked into a patient's room, started your assessment, began your care, and then asked yourself, is there a better way to do this? That question has driven my entire career. You see, I started my career as a young nurse in a neurological ICU in the 80s. As you might imagine, our patients were gravely ill with poor prognoses. Despite that reality, we had restrictive visiting hours, 15 minutes on the hour, and no visitation after 6 p.m. I remember vividly having to ask a husband to leave his wife's side as she was slipping away. You see, I was a rule breaker, and I worked night shift. So I would sneak a wife in so she could hold her husband's hand, or a son who flew in to kiss his father goodbye. But this experience in the ICU was the spark that ignited my research journey. I then got on a plane from New York City and came to Columbus, Ohio to pursue my master's degree. And you can guess what my master's thesis topic was. It was visitation hours and its impact on families in the intensive care unit. Shortly thereafter, I went on to pursue a PhD in nursing with the dream of becoming a hospital-based nurse scientist. Now you might ask, what does a hospital-based nurse scientist do? It's a good question. We transform the questions of the bedside nurse into evidence. Well, you might ask, how is that done? See, it starts with a firm belief. It's the belief that every nurse has a superpower. It's the power to know when something isn't quite right. It's the feeling of cognitive dissonance. So here's the magic. You, as the frontline nurse, bring your wisdom and your knowledge and that important question. And my role as the hospital nurse scientist is to bring my knowledge of research methods and tap into and amplify your superpower and change the question from, why are we doing it this way, to, how can we do this better? Let me give you an example right here at Ohio State University on our labor and delivery unit. We have a very successful practice of nurse midwives, and they have successfully worked with mothers to have water births over numerous years, also called hydrotherapy. And then the American Colleges of Obstetrics and Gynecology came out with a guideline saying that water birth was no longer a safe practice. And just like that, they were asked to stop the practice. So they went to the department chair and asked him if he might consider. And he said he would if they did it in the context of a research study and they brought him the evidence. So they came to me, and together we designed a study. We enrolled 230 women. A third of them were women who labored and delivered in the tub. A third of them were women who labored in the tub and then chose to get out of the tub for the delivery. And a third who were a control group who had no water experience during their birthing. And we found unequivocally that water birth was a safe practice for low-risk women. And water birth was reinstated at OSU, and they've gone on to be very successful with this practice. But even more exciting is the paper that we published went on to be one of the foundational papers for the change in the national guidelines for water birth. So now water birth is practiced at selective places across the United States. Another example started during COVID, March of 2020. Anecdotally, nurses across the country were reporting an escalating number of violent assaults, both physical and verbal. And then, thankfully, the pandemic subsided. But nurses continued to report that these assaults remained high. So a group of nurses from OSU came to me and said, this is something that we need to study. So together we put together a research proposal and a survey, and we studied nurses at 3 institutions, 2 in Ohio and 1 in New Jersey. And what we found was 70% of nurses reported verbal assaults and 40% reported threatening physical assaults. But what was even more compelling was that we found that as the number of assaults went up, the mental health of the nurses went down. And moreover, as the number of assaults went up, the desire to leave the profession went up. And so what we've learned from this is that it is insufficient to just describe a phenomenon. Data is nice, but we need testable solutions. We're about to embark on a study on our behavioral health unit here at Ohio State University. Imagine this. A nurse has been assaulted. She then has the opportunity to step into a virtual reality headset for about 15 minutes and step away and immerse him or herself in a relaxing meditative experience. During this, we will measure stress and anxiety pre and post the virtual reality experience. What's exciting about this is that if indeed this is successful, it's scalable and can be done in other parts of the hospital. So we started this talk with that young nurse in the neurological ICU. It's been 40 years, and that young nurse still lives inside of me. And I'm grateful because every day I have the opportunity to work with the finest nurses in the country here at Ohio State University. And together, we ask that important question. So my call to all of you is, don't just break the rules silently in the dark like that young nurse in the neurological ICU. Question them loudly and boldly. And I challenge all of you to create the evidence to write the next chapter on how we can best deliver care. Thank you.